Welcome to Oral Hypoglycemic Agents, a complete animated guide covering classification, mechanism of action, and clinical applications. Oral hypoglycemics are reserved for type 2 diabetes, but only when diet and exercise have failed. They are most effective in patients older than 40 at disease onset, with fasting blood sugar under 200 mg per deciliter, in obese individuals, disease duration less than 5 years, insulin requirement under 40 units per day, and absolutely no ketoacidosis or major complications. Oral hypoglycemic agents are classified into 5 major families. First, the sulfonylureas, divided into first-generation agents like tolbutamide and chlorpropamide, and second-generation agents such as glibenclamide, glipizide, glympyride, and gliclazide. Next, the biguanides, including metformin and fenformin. Third, the meglitinides, represented by repaglinide and nataglinide. Fourth, the thiazolidinediones, or glitazones, rosiglitazone and pioglitazone. And finally, the alpha-glucosidase inhibitors, acarbose and miglitol. Sulfonylureas are chemically related to sulfonamides and require functional pancreatic beta cells to work. Their mechanism is elegant. The drug binds to the SUR1 receptor on ATP-sensitive potassium channels in the beta cell. This closes the channel, depolarizing the membrane. Voltage-gated calcium channels then open, intracellular calcium rises, and insulin is secreted. Extrapancreatically, they also increase insulin receptors on target cells and suppress hepatic glucose production. Pharmacologically, they lower blood sugar, reduce free fatty acids and cholesterol, and restore leukocyte microbicidal function. They are well absorbed orally, highly protein-bound, metabolized in the liver, and excreted in urine. However, they are contraindicated in pregnancy and renal disease, carry a real risk of hypoglycemia, and chlorpropamide is uniquely used in diabetes insipidus. Biguanides, primarily metformin, do not induce insulin secretion. They are anti-hyperglycemic, not true hypoglycemics. In the liver, they suppress gluconeogenesis and glycogenolysis. In muscle, they increase glucose uptake and utilization. In the gut, they reduce glucose absorption and promote conversion to lactate. Clinically, they improve lipid profiles by lowering VLDL and LDL while raising HDL, suppress appetite, and crucially, do not cause weight gain. Meglitinides, repaglinide and nataglinide, are quick, short-acting prandial agents. They share the same pancreatic beta cell target as sulfonylureas, the SUR1 potassium channel. With a 1-hour onset and 4 to 5 hour duration, they are taken before meals to blunt postprandial spikes. Their advantage is a markedly lower risk of serious hypoglycemia, provided the patient does not skip the meal. Thiazolidinediones, or glitazones, rosiglitazone and pioglitazone, are true insulin sensitizers. They are selective agonists of the nuclear receptor PPAR-gamma, found in adipose tissue, muscle, liver, and heart. By activating this receptor, they turn on genes that enhance insulin sensitivity, glucose uptake, and lipid metabolism. They are first-line therapy for type 2 diabetes, used alone or in combination. However, watch for weight gain, fluid retention, and heart failure exacerbation. Alpha-glucosidase inhibitors, acarbose and miglitol, work locally at the brush border of the jejunum. Acarbose is a natural oligosaccharide from the bacterium Actinoplanes utahensis. They physically block alpha-glucosidase enzymes, preventing the breakdown of complex carbohydrates into absorbable sugars. This specifically targets postprandial hyperglycemia. Be prepared for flatulence, abdominal discomfort, and occasional transaminase elevations. To summarize the comparison, sulfonylureas and meglitinides are insulin secretagogues with genuine hypoglycemia risk and weight gain. Biguanides, thiazolidinediones, and alpha-glucosidase inhibitors are anti-hyperglycemics with low hypoglycemia risk, though glitazones still cause weight gain. Here is the critical clinical pearl: biguanides, thiazolidinediones, and alpha-glucosidase inhibitors are formally classified as anti-hyperglycemic agents, not true hypoglycemics, because they do not elevate circulating insulin and rarely cause hypoglycemia. Only sulfonylureas and meglitinides are true insulin secretagogues. To conclude, sulfonylureas stimulate insulin secretion via potassium channel blockade. Biguanides like metformin shut down hepatic glucose output and boost peripheral uptake. Meglitinides provide prandial insulin spikes. Thiazolidinediones sensitize tissues via PPAR gamma. And alpha-glucosidase inhibitors block intestinal carbohydrate digestion. Understanding these distinctions ensures safe, effective, and individualized diabetes therapy.